You know, for a lot of parents, the story starts with something scary, like a sudden high fever, or maybe just a confusing note on a prenatal ultrasound. So today, we're going to break down the condition that's often behind it all, vesicoureteral reflux, or VUR for short.
Okay, that's a pretty strange question, I know, but honestly, it gets right to the heart of what VUR is all about. Just picture your body's plumbing for a second. It's supposed to be a system of one-way streets, right? Well, imagine if all of a sudden things started flowing in reverse. That, right there, is the basic idea behind this condition.
So here's how things are supposed to work. You've got these tubes, called ureters, that run from your kidneys down to your bladder. And right where they connect, there's this tiny, amazing one-way flap valve. Its only job is to let urine in and not let it back out. But with VUR, that little valve, well, it doesn't close all the way. And that's what allows urine to flow backward, to reflux, back up toward the kidneys.
Right, so the big question for families is, how do you even find out this is happening? Well, it turns out there are usually two very different ways this condition comes to light. It's either discovered before the baby is even born, or it shows up sometime later in a young child.
And these two paths are really different. The first one, you could say, is proactive. A routine prenatal ultrasound might show some swelling in the baby's kidneys. It's a clue that lets doctors be on the lookout and ready to act right after birth. But the second path, that one's reactive. It usually starts with a urinary tract infection, or a UTI in a little one. That UTI is like an alarm bell going off, telling everyone that something's not quite right with the body's plumbing.
And for so many parents, these symptoms are the very first sign that something is wrong. You know, a fever that just comes out of nowhere with no other obvious cause, that's often the trigger that makes a doctor say, hey, let's test for a UTI. And from there, especially in really little kids, that investigation can lead straight to a VUR diagnosis.
Okay, so getting a diagnosis is really just the first step. The next, and honestly the most critical question, is how severe is it? See, VUR isn't a simple yes or no thing. It's a spectrum. And to figure out where a child falls on that spectrum, doctors use a special imaging test. It's called a voiding cystourethrogram, or VCU. It basically lets them see the reflux happening in real time.
And this is maybe the most important thing to remember through all of this. Not all reflux is the same. Not even close. How severe that backflow is, that's what's going to guide every single decision from here on out.
Let's actually look at this grading system. You can see, grade I is, well, it's pretty mild. Just a little puff of urine going back into the ureter. But as you go up the scale, things get a lot more serious. By the time you get to grade 5, you've got a ton of urine forcing its way all the way back up. It's so forceful that it can make the ureter twist and the kidneys swell up, and that is when the risk of permanent kidney damage gets very real.
So once you know the grade, that brings doctors and parents to a really important crossroads. The big question becomes, okay, what do we do about it? How do we treat this?
And basically, there are three main paths you can take. The first one is the least invasive. It's just observation. This is often for the lower grades because the amazing thing is a lot of kids will actually just outgrow VUR on their own. Then there's the middle road, medical management. This means using a daily low-dose antibiotic to keep infections away while you wait and see if the body can heal itself. And finally, for the really high grades or if infections keep happening, there's surgery, which is designed to be a permanent fix for the plumbing problem.
But it's not just about the grade on that chart. Doctors are looking at the whole picture. How old is the child? Is there any kidney scarring already? Are they getting those breakthrough infections even while they're on antibiotics? It's a very personal decision, tailored to each specific child.
So let's say surgery ends up being the right path. What does that actually look like? I mean, how in the world do surgeons get in there and fix a tiny, faulty valve inside a child's body?
Well, the core idea is actually pretty brilliant, and it's all about physics. They're not putting in some artificial part. Instead, they basically reroute the ureter's path through the muscle of the bladder wall, making its tunnel longer. This new, longer tunnel acts like a natural flap valve. Think about it. When the bladder fills with urine, the pressure builds, and that pressure just squeezes the tunnel shut. It's that simple, and there's even a kind of magic number for it. A 5-to-1 ratio of tunnel length to the ureter's width. That's the sweet spot that makes sure it works, kind of like stepping on a garden hose to stop the flow of water.
Now, there are two main ways surgeons can achieve this goal. You have the traditional open surgery, which has been the gold standard for a very long time. And then you have the more modern, minimally invasive approach using robotics.
So with the open surgery, the surgeon makes an incision and works directly on the bladder.
They'll create this little channel, or a trough, in the bladder muscle, gently place the ureter inside it, and then stitch the muscle right over the top. And voila, that's how they create that new, longer tunnel that's needed to stop the reflux.
The robotic approach, on the other hand, gets the exact same job done, but in a totally different way, from the inside. Instead of a larger incision, there are just a few tiny little entry points for the instruments. And what the surgeon sees is this incredible, magnified 3D view. It gives them the precision they need to do that same delicate rerouting, just with robotic arms.
Of course, the surgery itself is a huge deal, but it's really just one part of the journey. For families, what really matters is what comes next. What's recovery like? And what does this mean for their child's long-term health?
And the news here is just fantastic. We're talking about a success rate that approaches 98% for open surgery in kids with otherwise normal bladders. I mean, think about that. A 98% chance of completely fixing the reflux. It's truly one of the most successful surgeries in all of pediatric urology.
The post-op journey follows a pretty clear, predictable path. First, they'll stay on some antibiotics for a little while, just to protect everything while it heals up. A few weeks later, they'll get an ultrasound to make sure the kidneys look happy and healthy. And sometimes, they might do another one of those VCUG tests, just to be 100% sure the reflux is gone. For most kids, that's it. The journey is over. The only exception is for kids who already had some kidney scarring. They'll likely need some simple long-term checkups, like getting their blood pressure monitored.
And all of this brings us to a really hopeful final thought. When you look at the big picture, the story of VUR is really one of amazing progress. We're getting so much better at finding it early, sometimes before birth, and the treatments are so incredibly effective. So the whole goal is starting to shift. It's not just about fixing a problem anymore, it's about preventing the serious consequences, like kidney damage, from ever happening at all.